So the incidence of congenital heart disease requiring specialized cardiac care is estimated to be about 500 to 600 per 100,000 live births, and approximately 170 per 100,000 live births have critical congenital heart lesions, defined as those who are ductal dependent or require surgical attention in the first month of life. So we try to be well prepared for cases of neonates with congenital heart lesions, and that's why a lot of emphasis has been put on trying to diagnose patients ahead of time in the prenatal period to detect any congenital heart lesions. However, most studies have suggested that in the best of hands and the best centers, not more than 60% of cases can be diagnosed prenatally, and still there are cases which are born and carry congenital heart lesions that have not been detected on prenatal echocardiography. So the patient, if they have congenital heart lesions, a lot of time when they are born, they appear normal at birth, except for few cases. And to avoid having cases that are being missed and discharged, the pulse oximetry screening tool was also developed to use that as a technique to detect congenital heart lesions in patients who are asymptomatic, just to fill the gap of cases that have not been evaluated or detected prenatally. Despite that, still there are certain cases that are being born and still carry congenital heart lesions. Some of them are critical that have not been detected on fetal ultrasound or by the pulse oximetry testing afterwards. So these patients carry a major challenge for all of us. And I think we have to concentrate on trying to increase the awareness of primary care physicians to be more in tune with patients who may have congenital heart lesions, and the best way to detect the patients that have lesions that require intervention, especially the ones that carry critical congenital heart lesions. So the infants and younger children are definitely more challenging to diagnose than the older children. And the one thing that always carries important information for the pediatrician is the presence of heart murmur. And the heart murmurs usually are the main reason for suspicion of congenital heart disease in the primary care setting. And then afterwards, usually the patient is referred to a cardiologist. However, the murmurs on physical exam are considered most of the time innocent, and many children are not referred to a cardiologist. On the other hand, all infants with murmurs referred to cardiologists. Out of all of those patients, only 40 or 45% of them are diagnosed as having cardiac anomalies. So there are certain things that we need to be aware of. First of all, the innocent heart murmurs, we have to try to be more experienced with the nature of those murmurs. Usually the murmurs are systolic or continuous murmur. The systolic murmurs that are indicative of an innocent flow murmur usually either are Still's murmur, or what they call it the vibratory systolic LV outflow tract murmur, the pulmonary artery systolic murmur, branch pulmonary artery stenosis murmur, subclavicular systolic murmur, systolic mammary stoffel, and aortic sclerotic systemic murmur, and cardiorespiratory systolic murmur. Also, there are continuous murmurs like venous hum or cephalic continuous murmur. So each congenital heart lesions have a variety of severity, and also that makes it challenging for all of us to be able to pick up a diagnosis of certain disease, especially if it has the milder end of the spectrum of the diagnosis. So basically, the majority of the congenital heart lesions fall within this range of gray area, meaning that you don't have a clear-cut findings that you would read in the books about a specific diagnosis. And I'll give you an example of that. And the very nice example that I like to use for my demonstration of this is patients who have tricuspid atresia. Those patients come in so many different varieties, patients who have transposition or patients who don't have transposition. As an example, patient without transposition, they could either present with as no VSD, or they could present with restrictive VSD, or they could present with large VSD. And assuming that we have a good interatrial communication, if the patient presents with no VSD and there is pulmonary atresia and tricuspid atresia, the patient from the beginning will actually have cyanotic presentation that requires immediate intervention and starting prostaglandin. If you have somebody who has pulmonary valve stenosis and a restrictive VSD, those patients usually will be relatively reasonably saturated with sats mostly in the mid to high 80s, and they will be stable clinically without even symptoms of heart failure. On the other hand, if the same diagnosis happen in a patient who has no pulmonary stenosis and unrestricted VSD, once the patient pulmonary vascular resistance drop, the patient will have excessive pulmonary blood flow, and this patient will have signs of heart failure when the PVR drops to the normal level between 3 to 4 weeks of life. And at that time, the patient would require to have pulmonary artery banding to limit the amount of pulmonary blood flow. So we're talking here about one diagnosis with multiple presentations, multiple potential presentations. That's why we have to be, again, well aware of the different cases and how each one of them presents and how the best intervention for them would be done. Another example are patients with the trilogy of Fallot. We can have a spectrum of cases ranging from pink death with a patient who has very mild RV outflow tract obstruction with saturations in the 90s without visible cyanosis, to a patient with moderate pulmonary valve stenosis with acceptable saturations in the high 80s, to patients who have pulmonary atresia that once the PDA closes, the patient actually will have severe cyanosis that requires a BT shunt after the prostaglandin is instituted. So there are several things that I always like to simplify to my colleagues in the primary care sector to try to approach congenital heart lesions in a logical way. We try to look at several factors. One of them is the timing of presentation. Usually congenital heart lesions has a bimodal presentation, meaning that a patient either presents with ductal dependent lesions in the first few days of life. When the PDA closes, the patient will have either decreased systemic perfusion or decreased pulmonary perfusion. Or it could be cases that have shunt lesions, and those type of cases will develop into heart failure symptoms, which will happen later between the age of 1.5 to 2 months. The other thing that is important is the type of presentation that we're dealing with, whether the patient is presenting with cyanosis, with heart failure, or with shock. Again, that will give you an idea. If you have a patient with cyanotic or in shock in the first week of life, then you have to consider ductal dependent lesion of pulmonary or systemic dependency, or you have a later presentation with heart failure once the patient reaches the time when the PVR drops to the normal level. Other things that will be helpful also for the primary care physicians are the associated non-cardiac or genetic anomalies. As you all know, for example, trisomy 21 is well known to be associated with congenital heart lesions, and frequently they could have AVSD, which presents with heart failure, again, when the PVR decreases to the normal levels. So this is the age of presentation that we just discussed. Other things that are important are patients in the first year of life. It's important to know that most cardiovascular emergencies due to congenital heart lesions occur in the first year of life, and most of these infants are very challenging in making the diagnosis because they often appear markedly distressed, but there is no specific signs or symptoms. All these signs or symptoms resemble a lot of the common pediatric illnesses. However, the one thing that is also challenging to the primary care physician is managing these other diagnoses that have the same type of presentation, and the type of interventions you make for them could actually make a patient with congenital heart lesion worse. For example, if a patient presents distressed and you give, expectedly a lot of patients are seen with respiratory illnesses, are given oxygen, for example, and in a patient who has parallel circulation, you give oxygen, you drop the pulmonary vascular resistance in the case of hypoplastic left heart, and the patient will become extremely bad because he will flood his lung and his systemic perfusion will be compromised. So the differential diagnosis of congenital heart disease, other illnesses that might present with signs and symptoms similar to congenital heart lesions are respiratory, like bronchiolitis, pneumonia, hemangioma, reactive airway disease, hemodynamic abnormalities like sepsis or anaphylaxis, GE reflux or tracheoesophageal fistula, and also toxic and metabolic diseases. There are few statements that I always concentrate on and try to raise the awareness of my colleague about it, is babies with congenital heart disease are seldom critically ill immediately after birth. And usually problems with ventilation are almost always the cause of respiratory failure. And usually the management of those conditions most of the time relates to respiratory illness. So that's another challenging thing, that the patient, again, congenital heart disease doesn't always present critically ill, and we always have to think about respiratory illnesses first. The other thing that's important is there are certain issues that we need to concentrate on in our examination and history taking to identify whether the patient has congenital heart lesion or not. One of them is history of poor feeding for several days. This patient may have congenital heart disease, especially the ones that requires that causes heart failure. Also, absence of fever. If the extremity, upper extremity blood pressure is elevated and the lower extremity blood pressure is decreased, or there is absent lower extremity pulses. If the oxygen desaturation is out of proportion and of what is expected based on the physical examination, abnormal femoral pulses, signs of congestive heart failure, or abnormal cardiac examination, especially if the patient has one of those type of murmurs. Those murmurs are considered a high suspicion murmur for presence of congenital heart disease, including pansystolic murmur, if the intensity is greater or equal than 3, if the point of maximal intensity at the upper left sternal border, located in the upper left sternal border, if you have a harsh quality murmur, if you have an early mid-systolic click, or abnormal second heart sound. So in a patient who is critically ill, many of these findings are present and intensified. And any murmur should raise suspicions for congenital heart disease in patients who present with tachypnea and or shock. And the presence of one of those 6 cardinal signs that we just talked about, the type of murmurs that we just mentioned, or the abnormal second heart sound, should increase the suspicion of the presence of congenital heart disease and should lead to an immediate pediatric cardiology consultation. Now, the type of cardiovascular presentation is important. If the patient has cyanosis with increased pulmonary blood flow or decreased pulmonary blood flow, if the patient has is acyanotic, usually those are the ones who are shunt lesions like VSD or AVSD, or if they have left-sided obstructive lesions like hypoplastic left heart or coarctation of the aorta. Now, the pink child in respiratory distress suggests acyanotic congenital heart disease, like left to right shunting, for example. Blue cyanotic child in little respiratory distress suggests right to left shunting or mixing lesion. A patient who is gray and chalky suggests left-sided obstructive lesion. So this is, again, another simplified classification of patients who have cyanotic or acyanotic lesion. If you have a cyanotic lesion and you have decreased pulmonary blood flow, we should consider cases like tetralogy of Fallot, tricuspid atresia with severe stenosis of the pulmonary valve or pulmonary atresia, Epstein's anomaly of the severe nature, severe pulmonary valve stenosis, or pulmonary atresia with PSD, patients with increased pulmonary blood flow, transposition of the great arteries, common arterial trunk, or total anomalous pulmonary venous return. In acyanotic lesion, you could have either left heart obstructed lesion, like coarctation, aortic stenosis, or hypoplastic left heart, or cases who have left to right shunting, like PDA and VSD. But those patients typically, with this type of presentation, they will present later in life, not in the first few days of life. Now, patients with increased pulmonary vascular bed, again, are listed in this table. Decreased pulmonary vascularity in congenital heart lesions, again, is listed in this table, as we just talked. Now, when you combine the age subcategory along with the type of presentation, then you can narrow down your differential diagnosis. So in the first month of life, you have two types of lesions, usually lesions requiring the ductus to perfuse the pulmonary flow, or lesions requiring the duct to perfuse the systemic blood flow. And those are, in the first category, the tricuspid atresia, pulmonary atresia, tetralogy of Fallot with pulmonary atresia, and so on. And in the systemic lesions that require ductal patency are cases like critical coarctation, critical aortic stenosis, aortic atresia, interrupted aortic arch, and so on. You have also cases of pulmonary venous obstruction like TAPVD, excessive left to right shunting like truncus arteriosus, or increased arterio venous pressure difference like in AV fistula. Now, when you have a later age presentation between 2 to 6 months of age, usually this is secondary to decreased pulmonary vascular resistance, and those are the cases that are shunt lesions like ventricular septal defect, AVSD, large ductus, and unobstructed TAPVD. Or you have cases that you have coronary circulation dependent on the pulmonary pressure, and when the pulmonary pressure drops to the normal levels, then the coronary perfusion becomes compromised and the patient will develop heart failure secondaries to severe LV dysfunction, and this is the clear example is L Kappa. Now, at any age, patients could present with acquired heart disease like myocarditis or idiopathic cardiomyopathy or pericarditis or a cardiac tumor, or arrhythmia also could be implicated in any age, like patients presenting with SVT or complete heart block. Now, there are three major things that present with cyanosis that we need to be aware of. Discordant VA connection like TGA, pulmonary obstruction with avenue for right to left shunting, and common mixing situation with common atrium and single ventricle. And the cyanosis with some important aspects that we have to be aware of are some patients with cyanotic congenital heart disease with right to left shunting and increased pulmonary blood flow. As an example, is TAPVD or truncus. Those patients may have lower saturation but undetectable cyanosis because their SATs are above the 85% cut, which usually is required for the patient to be visually detected as having cyanosis. So those cases could sometimes be missed because the patient doesn't visually appear cyanotic. And also, on the other hand, patients who have polycythemia may appear cyanosed, but they don't have congenital heart disease. Now we can use hyperoxia test, which is another way of trying to identify the patients with congenital heart lesions, or we can also use pulse oximetry testing, but it's not always reliable. So when we have patients that mix different type of problems together, you have also more confusing issues. For example, transposition with VSD and ASD and PDA, you have connection at the atrial level or ventricular or the great artery level. When you have TAPVD, you have the mixing happening at the atrial level. When you have a truncus, then you have the mixing happening at the ventricular and arterial levels. And in mild cyanosis, some patients present with mild sinuses and heart failure, and they have sometimes respiratory symptoms like tachypnea. Now, I'll give you an example of X-ray patterns that will help you in making specific diagnosis. That will be an additional factor for you to look at when you are trying to identify a patient with congenital heart disease. This is an example of a cyanotic infant who present with decreased pulmonary perfusion and the typical boot-shaped heart. As you all know, this case is a typical presentation on an X-ray of patient with tetralogy of Fallot. In this case here, you have the boot-shaped heart, and the reason for that is because the apex of the heart is shifted upward, and you have decreased pulmonary segment size, so the heart will actually become shaped as a boot. And with the decreased pulmonary vascular bed, that will actually indicate that this patient probably has tetralogy of Fallot with decreased pulmonary blood flow. Another example is a patient also who present with severe cyanosis from birth. And when you look at the X-ray, you see this wall-to-wall heart. This is a typical X-ray of a patient with severe Epstein's anomaly of the tricuspid valve. A patient who presents, for example, at 3 weeks of life with mild cyanosis and tachypnea. And this patient here, as you notice here, has a narrow mediastinum and the heart that looks almost like you have what they call it, the term they use is an egg on a string. This patients usually who present with this type of X-ray, they have a transposition of the great arteries with good mixing. And this is why sometimes they present with mild cyanosis and tachypnea when there is increased pulmonary blood flow. This is another example of a patient with also mild cyanosis and tachypnea at 1 month of age. This is the typical snowman shape of the X-ray of the cardiac shape or the cardiac silhouette. And the reason for this shape, which what we call it the snowman appearance, is because we have the pulmonary venous return coming back to the confluence on the left side behind the left atrium, and actually it's draining through a vertical vein on the left and joining the innominate vein into the SVC, and this is the reason why we have that shape on the X-ray. So this X-ray should raise the suspicion in an infant who presents with mild cyanosis and tachypnea at 3 to 4 weeks of life. Another example of an X-ray pattern that is helpful in making the diagnosis is this patient who is 2 months of age who presents with wheezing and tachypnea and suspected to have respiratory problem. However, when you do X-ray, you find that the heart is extremely large on X-ray. And when you do the ECG, you have deep T wave in the precordial lead, which is consistent with the patient who has L kappa with severe LV dysfunction. Now, associated non-cardiac genetic anomalies could also help you to direct your suspicion into a specific diagnosis. For example, as I just talked a few minutes ago, patients with Down syndrome have high frequency of congenital lesions. One of the most common one is complete AVSD. Patients with SLE, for example, could have complete heart block if the mother had SLE. Diabetes, the patient may present with cardiomyopathy or TGA or VSD. Trisomy 18, we have high frequency of VSD and PDA and pulmonary hypertension. And also patients with 22q11 deletion have also conotruncal defects. So when you see a patient with this type of genetic abnormalities, you should suspect the associated lesions that are seen with these cases. This is an example of a patient with a trisomy 18 with typical findings that are consistent with Edwards syndrome. Those patients have usually VSD and PDA and pulmonary hypertension. This is a patient with 22q11 deletion. Those patients, again, have high frequency of conotruncal defects and should also be investigated whenever a patient is born with features that are consistent with this type of diagnosis. This is a patient with webbed neck who has Turner syndrome. So this patient also should be suspected of having coarctation of the aorta, which is seen in a relatively high frequency in this type of patients compared to the general population. So I'm going to start now by discussing more left-sided obstructive lesions. Those are the most common pathologies, either aortic stenosis or hypoplastic left heart, interrupted aortic arch, or severe coarctation of the aorta. Now, in the neonatal period, as the PDA begins to close, severe obstructive left heart lesions will develop hypoperfusion and shock and pulmonary edema because of increased pulmonary flow and decreased pulmonary perfusion. The milder form of these lesions, on the other hand, like mild AS or mild coarctation, will present less acutely and sometimes could be missed. And they are usually managed when they are diagnosed, but on more of an elective basis, not on an acute basis. So things that are important to keep in mind about left heart obstructive lesion, usually complete or severe obstruction of left-sided lesion is incompatible of life unless there is shunting. So patients usually with severe coarctation of the aorta, for example, with a PDA that has closed already, these patients will present with severe shock, and sometimes it will be very challenging to revive them and to be able to go on to the next step of managing them surgically. Any infant in the first week of life, also with decreased perfusion, hypertension, or acidosis, should be considered a candidate for prostaglandin. That's extremely important because sometimes primary care physicians are hesitant about starting prostaglandin. We always tell them that it won't harm to start prostaglandin if you have a suspicion, and that will actually at least put you in a safe zone in terms of cases that could potentially be ductal dependent, and the PDA will start to open up and you have better pulmonary or systemic perfusion, as opposed to waiting until you have a definitive diagnosis. Any neonate in shock that does not respond to fluid or pressors also has left-sided obstructive lesion unless proven otherwise. And cardiovascular collapse in the first month of life is the left-sided obstructive lesion unless proven otherwise. Those are very important statements that I hope that you will keep in mind when you manage your patients. In terms of management, the management depends on several things. Depends on the prompt and accurate diagnosis, on instituting the proper and appropriate therapeutic measures, and afterwards, when the patient is stabilized, referring to a specialized treatment center if necessary. Now, during stabilization, the physical examination should include blood pressure in all extremities. Murmur may be audible, but may not be audible in all congenital heart lesions. Absence of a murmur does not exclude cardiac defect. Sometimes we tell our colleagues in the primary care sector that also concentrate on the second heart sound. The second heart sound also extremely important to identify, especially the cases of cyanotic lesion, because usually the second heart sound is single. Chest X-ray and ECG also should be included in the evaluation. Now, important things about the management is the general guidelines for the management. You have to prevent hypothermia. You have to maintain a neutral thermal environment. You have to monitor and do prompt treatment of hypoglycemia and hypocalcemia, monitor acid-base status, and the treatment of metabolic acidosis and management of respiratory acidosis. Those are very important to make sure that your picture is not confused by those factors that have not been managed properly. Starting prostaglandin is crucial. Usually we start at lower level if we have a diagnosis and we have already a patent ductus. So we could start with 0.01 or 0.02 microgram per kilo per minute. But if you have a closing PDA or almost closed PDA, then you go with the higher doses like 0.05 up to 0.1 microgram per kilo per minute. Most probably prostaglandin is effective earlier in life, but sometimes the patient might present at a later stage when the PDA have been closed for a few days, and that makes it a little bit more challenging. And sometimes it's impossible to open the PDA with prostaglandin. So a small ductus can be dilated, but an already closed ductus, as I mentioned, could be very difficult to reopen. Some side effects of prostaglandin include apnea in 10% of the cases, elevation of the temperature in 10% of the cases, muscular twitching, and severe flushing. And patients who also is getting prostaglandin should be watched closely for apnea, especially at higher doses. Once the oxygen saturation improves, prostaglandin could be weaned down to a lower dose, ranging from 0.01 up to 0.03. No more than 40% of humidified oxygen is necessary, since there is a fixed intracardiac right to left shunting, and echocardiography and sometimes cardiac cath are required based on the type of presentation. Once the diagnosis is established, a permanent way to provide pulmonary flow should be considered by cath or by surgery. Now, there are two congenital heart lesions that does not respond to prostaglandin, or because it's not ductal dependent. Those are TAPVD and truncus arteriosus. So we have to keep that in mind. And key points I want to go over with you after we talked about different cases and different presentations. Functional closure of the ductus may be delayed in children with congenital heart lesion, and as a result, patients with ductal dependent lesions may become symptomatic after being discharged. That's why it's a challenge to diagnose them at the neonatal nursery, and we have to have a high index of suspicion and to be very vigilant about the signs and symptoms we discussed earlier in this lecture. The timing of presentation is bimodal, as I discussed earlier. Patient with a ductal dependent defect will present in the first month of life, while patients with predominantly left to right shunting lesions will present later in life after the PVR have dropped. A ductal dependent congenital heart lesion should be considered in any neonate less than 1 month of age who presents with sudden cardiovascular collapse. This lesion has the highest incidence of mortality prior to surgical correction. The decision to initiate prostaglandin should be based on clinical finding and high index of suspicion of ductal dependent lesions. So please do not delay initiation of prostaglandin in case that is highly suspicious of ductal dependent congenital heart lesions. You should not wait for a definitive diagnosis by echo, which the valuable time you will be losing could actually have a terrible adverse effect on the outcome of the patient. The diagnosis of congenital heart disease should be considered in any infant less than 1 year of age who presents with cyanosis, tachypnea, or shock, and suspicion should be enhanced by the history, beside the other things we talked about, of poor feeding and poor weight gain, absence of fever, auscultation of a murmur, hepatomegaly, cardiomegaly on a chest X-ray, or abnormal ECG, especially the presence of left axis deviation, atrial enlargement, or ischemic changes. And upper and lower extremity blood pressure and saturations should be measured on all infants if those patients present specifically with cyanosis, tachypnea, or shock. Moderate to severe congestive heart failure in infant with heart disease, usually they have a history of less than 3 ounces of formula per feeding or greater than 40 minutes to finish feeding. They have respiratory rate greater than 60, and they have usually an enlarged liver on an average of 2.5 centimeter below the right costal margin. If a ductal dependent lesion is suspected or a patient is presenting after stage 1 palliation of a single ventricle lesion, supplemental oxygen should be titrated to achieve a saturation of not more than 80 to 85%, because when you flood the patient with oxygen, you decrease the pulmonary vascular resistance, and you will actually cause worsening of the patient's status by flooding his lung and increasing his pulmonary perfusion as opposed to the systemic perfusion. Many patients with heart lesion will have increased pulmonary reactivity or pulmonary hypertension. So we should try to avoid any factors that will stimulate pulmonary vasoconstriction, like agitation, hypoxia, acidosis, and pulmonary hyperinflation. So those things we need to be aware of because they will make actually the clinical picture worse, and they will make our job harder and harder to manage these patients. Thank you very much, and I hope this lecture got your satisfaction, and I'm open to any questions.